Okay, guys, so this is the third lecture about the orofacial pain. We are doing a series on the different pains which are considered as the orofacial pain, and we were discussing about the neuropathic pain in our previous lectures. We will continue at the moment with the neuropathic pains. So let's see what is orofacial pain, just for the revision. Orofacial pain is a frequent form of pain perceived in the face and or oral cavity. And as we know, and we have discussed already in our previous lectures, that there are multiple etiological factors which may cause pain in our orofacial region. Another type of neuropathic pain is because of herpes zoster, which is also known as shingles. Shingles or herpes zoster is a viral infection that causes an outbreak of a painful rash or blisters on the skin. It is caused by the varicella zoster virus, the same virus which causes chickenpox. Virus after the initial infection of chickenpox, it remains dormant in the sensory ganglia until it is reactivated due to some uh, chances that there would be some immunocompromised situation, like patient would be aging or patient would be having some disease which would be compromising their immune status. So reactivation occurs usually among the adults, and then it gives rise to shingles or herpes zoster. The rash most often appears as a band of rashes or blisters in one area of the body, which is supplied by that particular nerve which is affected. In the trigeminal region, the ophthalmic division is most commonly affected, but zoster may occur in the oral cavity or inside the mouth. If the maxillary or mandibular division of the trigeminal nerve, they are affected, either of the two. Clinically, it presents with the vesicles or erosions occurring over the mucous membrane of the upper jaw, palate, gums of the upper teeth, or the lower jaw, like tongue or gums of the lower teeth. This is the reason that's why the patient would be seeking the help of a dentist, like oral cavity is involved. So just to show you the picture, like they could the vesicles, they could appear on the body, they could appear on the face and intraorally as well. Signs and symptoms of shingles. Signs: severe unilateral. It is always unilateral. It is not crossing the midline. Deep-seated burning pain in the prodromal phase a few days before the rash and vesicles develop. The vesicles, they become weeping and crusting on the skin but remain as shallow ulcers in the mouth. Vesicles and ulcers, they are, as I told you earlier, they are unilateral in distribution, and this is one of the diagnostic features. Symptoms: if the maxillary division of the trigeminal nerve is involved, the hard and soft palates are affected unilaterally. If the mandibular division, then there will be extensive unilateral cutaneous lesions will also be present. With ophthalmic division involvement, which we call the Gazerian or Gazerian herpes, serious corneal ulceration may develop, which will lead to the loss of sight. The unilateral distribution of the lesions along the anatomical distribution of the dermatome is characteristic of the herpes zoster. I have already mentioned about it. So the treatment for the herpes zoster. Herpes zoster is usually treated with orally administered acyclovir 800 milligram 5 times daily for 5 days, or any other antiviral medication like maybe famciclovir or valacyclovir. The antiviral medications are most effective when they are started within 72 hours after the onset of the rash. Well, herpes zoster vaccine is also available, and the trade name is Shingrix. It is the recombinant zoster vaccine, or RZV. It is recommended to be given among the adults who are 50 years or above. RZV is administered intramuscularly in 2 doses, and they should be minimum 2 months apart and maximum 6 months apart. Shingrix contains a protein which is glycoprotein E from the varicella zoster virus, the virus that causes chicken pox. Complications which are associated with the herpes zoster, if it was ophthalmic involvement, then there will be loss of sight and there would be a chances of post-herpetic neuralgia in case of any of the nerves which are involved. Post-herpetic neuralgia. It is a neurological pain which persists after reactivation of the herpes zoster along the cranial nerve 5, that is trigeminal. So it's any of the division like uh, ophthalmic, maxillary, or mandibular, or seventh cranial nerve, that is the facial nerve. In that case, we call it Ramsay-Hunt syndrome. The ophthalmic division of the trigeminal nerve is most commonly affected. And we know the etiology, acute herpes zoster infection of the trigeminal ganglion and its peripheral branches. So clinically, in case of post-herpetic neuralgia, if we will go into the history, patient will be giving you the history of having vesicles. There will be pain, which would be burning, constant, chronic, and continuous, and is not going to be paroxysmal like trigeminal neuralgia or glossopharyngeal neuralgia. Pain, it will interfere with eating and brushing and affect only that dermatome which is supplied by that affected nerve. The overlying skin is often red as patients may scratch the skin to gain some temporary relief from that pain. Well, in post-herpetic neuralgia, the treatment could be topical and it could be systemic. Topically, a cream or an ointment, which is capsaicin, which is 0.025%, it is applied to the lesion. It is not going to treat the cause. It will just relieve the pain. Systemic, there are multiple various medicines they've been used, like tricyclic antidepressants, anticonvulsants, alpha-2 agonists, they were also being tried. Systemic lidocaine therapy was also tried, and then cryocautery of that area. The local cryotherapy can be applied directly to the areas of the shingles rash in order to directly reduce the pain and inflammation in those areas. Ramsay-Hunt syndrome. It is actually because of the involvement of the geniculate ganglion, and that's why it's known as geniculate herpes. So the signs and symptoms, it is caused by the herpes zoster infection of the geniculate ganglion, the ganglion of facial nerve. Pain occurs in the throat or ear, followed by vesicular eruption on the ear and fauces. Treatment is excision of the geniculate ganglion or cut of the motor portion of the facial nerve. Well, pharmacological or medicinal treatments can be given, like giving the antiviral therapy and high doses of the corticosteroids. If we look into the complications of Ramsay-Hunt syndrome, it may include permanent hearing loss and facial weakness. For most people, the hearing loss and facial paralysis associated with Ramsay-Hunt syndrome, it is temporary, but it could become permanent in some of the cases. Eye damage. The facial weakness caused by the Ramsay-Hunt syndrome may make it difficult for the patient to close their eyelids. So if it is happening, then there would be chances of the corneal damage, which may lead to the blurriness of the vision or even loss of the vision. Post-herpetic neuralgia, this painful condition occurs when a shingles infection, it damages the nerve fibers. We have already discussed about that. The messages sent by these nerve fibers become confused and exaggerated, causing pain that may last longer after other signs and symptoms of the Ramsay-Hunt syndrome, they have already faded. Causalgia. It is the pain arising after injury to a peripheral sensory nerve, for example, following a difficult extraction. Pain is due to aberrant nerve repair, and symptoms would be constant burning or boring pain at a site of previous trauma or surgery. It can sometimes mimic the trigeminal neuralgia. Signs would be scarring from previous surgery or trauma. And treatment is carbamazepine, the same medicine which we use for the trigeminal neuralgia or glossopharyngeal neuralgia. Now we are going to discuss the pain which would be due to some vascular region, like vascular reasons. So pain of the vascular origin. Migraine. It is a type of recurrent headache combined with autonomic disturbances, that is the aura. Incidence and age of migraine, usually it starts in the second decade and diminishes as the age advances. Well, women are more commonly affected as compared to men, and in 50% of the cases, there is a family history of migraine. If we look into the etiology of this migraine, it will be causing by initial constriction of the branches of the external carotid artery, causing the characteristic aura. And then there will be dilatation, which will be causing the headache. Well, migraine is of two types, the classical migraine, which occurs with aura, and migraine without aura. So the classical migraine, it is characterized by abrupt onset headache. It will be unilateral and deep throbbing. Headache may last 12 hours. It affects the frontotemporal region. Most commonly, it triggers from the frontal area. Unilateral, then secondary, it spreads to the entire cranium. Headache is preceded by aura symptoms. Prodromal pre-headache stage causes lethargy. Aura include a reversible sensory, motor, visual, and speech disturbance. Visual problems will be, patient would be complaining of seeing some flickering lights which would be appearing zigzag, and they will also complain of blurriness of the vision. Sensory problem, well, patient will be complaining of some numbness, then paresthesia. It is not like it is spelling mistake over here. So paresthesia and anesthesia of the face, and the motor problems will be unilateral muscle weakness in the face. Now the migraine without aura. Headache would be unilateral, throbbing, moderate to severe, accompanied by photophobia. These people, they cannot withstand light when they are having this problem. They want to draw the curtains and stay inside. Usually they want to even sleep, and they don't want to talk to anyone because they are also having phonophobia. Then there will be nausea and vomiting, and usually after emesis or vomiting, they feel better. This is aggravated by the physical exertion. Migraine. Precipitating factors of migraine are stressful events, physical or psychological events, then trauma, vasoactive foods like chocolates and bananas. Treatment is a drug sumatriptan. It is a triptan. It is from the class of the drugs called triptans. Then NSAIDs can also be given, like the aspirin or the ibuprofen or naproxen. So all those type of drugs which we call the analgesics or the COX inhibitors, NSAIDs. Opioid analgesics can also be given, and antiemetics can also be given. Differential diagnosis. Dentists should have the knowledge about migraine because it is important to differentiate between the TMJ dysfunction pain. It may precipitate a migraine attack in a migraine-prone patient. Nausea and photophobia are not accompaniments with the masticatory musculoskeletal disorder or jaw and tooth pain of the dental origin, whereas nausea and photophobia will be present in migraines. Now, the periodic migrainous neuralgia, which is also known as sphenopalatine neuralgia, cluster headache, or alarm clock headache. Well, it affects very young people, like between 20 to 40 years. Males are more affected as compared to female, and stress or alcohol may precipitate an attack. The etiology of this headache is vascular compression of the ganglion by branches of the internal maxillary artery. Internal maxillary artery, not internal carotid artery. Periodic migrainous neuralgia we are discussing. So its signs and symptoms: unilateral paroxysmal attack of pain, dull aching or burning headache. Unlike classic migraine, pain usually occurs at night, and patient they get awakened from their sleep, even deep sleep, because of the pain, and it occurs at the same time at night. That is why it is known as alarm clock headache. Pain is of rapid onset and short duration, and usually it may last for 30 minutes but can be prolonged for 2 hours. Pain is usually limited to the area around behind the eye and related maxilla. As I told you that the attacks they recur at the same time of the night, that is why they are known as alarm clock waking or alarm clock headaches, and are clustered often once every 24 hours and followed by a long period of remission. The remission could be for weeks, for months, or at times even for years, and then they come back. Autonomic symptoms may accompany periodic migrainous neuralgia, and they include nasal blockage, means patient will be having a feeling of a stuffy nose, nasal discharge, or at times even tearful eyes. Unlike migraine, there is no nausea or visual disturbance diagnostic feature, and these headaches they do not have any trigger zone. Well, the treatment for this sphenopalatine neuralgia or alarm clock headache, ergotamine or anti-inflammatory drugs, for example, indomethacin, they may be given. And advise the patient to avoid alcohol. Giant cell or temporal or cranial arteritis. Pain is caused by ischemia resulting from the arteritis, affects females more common as compared to males, and is restricted to the elderly people, means over 60 years of age. Symptoms: severe unilateral ache restricted to the temporal and frontal areas, that is side of the head and behind the eye. Pain can be brought by eating due to ischemia of masticatory muscles known as mesenteric claudication. The temporal and frontal skin and scalp may be tender to the touch. This is one of the few pain disorders with systemic upset, for example, lethargy, weight loss, and weakness. Ocular symptoms include loss of vision in one part of the visual field. Signs for this type of orofacial pain or headache: the temporal arteries may be occluded, pulseless, thickened, and tortuous. Well, the treatment for this is we have to see if the retinal arteries are involved. Then the intervention should be very, very rapid because there would be chances of deterioration in the vision. And there would be chances of acute necrosis of the facial tissues, which may occur as gangrene of the scalp, lip, or tongue. And that is why very high doses of corticosteroids they are recommended. So over here, we are done with our third part of this series, and soon we will be coming back with our fourth part of this series, where we will be discussing other type of pains like TMJ dysfunction and all other orofacial pains. Thank you very much.